Welcome to The Pulse, the official podcast of the Georgia State Medical Association.
Well, hello once again. Thank you for joining us. I am Dr. Julianne Adams Birt, president of the Georgia State Medical Association, and I'm also your host for this episode of The Pulse. I want to introduce a fellow, I could say that 2 times, a fellow Clarkite and as well a fellow graduate of Morehouse School of Medicine. That is what Dr. Michelle Staples-Horne and I have in common. Let me tell you a little bit more about her before I start singing our chants for CAU and Clark College.
Yes.
So, Dr. Michelle Staples-Horne is currently the medical director for the Georgia Department of Juvenile Justice. She received her MD degree from Morehouse School of Medicine and her MPH from Emory University. She holds both BS and MS degrees from Clark Atlanta University. She received the American College of Correctional Physicians Armin Start Award in 2013, the NCCHC's Bernard P. Harrison Award in 2016, and the American Correctional Association's E.R. Cass Award in 2023. Dr. Staples-Horne serves on the NCCHC Juvenile Health Committee and on the Accreditation Council for Graduate Medical Education's Correctional Health Advisory Council to develop a correctional medicine fellowship program. She has served on numerous advisory boards to organizations and provided educational training and legal consultation for academic institutions, states, and local jurisdictions. Dr. Staples-Horne has authored numerous publications for several scientific journals, magazine articles, and book chapters on correctional healthcare. Please help me welcome Dr. Michelle Staples-Horne.
Thank you so much, Dr. Adams Birt. And as I said, my colleague, at least twice, we're a part of the Atlanta Medical Association as well. And so thank you so much for this opportunity to speak about corrections in general and correctional health specifically. So I would love to start the conversation.
Absolutely. So as a host, I usually am trying to come to these conversations a little, feel like I got a little bit of knowledge. But Dr. Staples-Horne, I'm pretty like green. I'm like correctional health. Like people actually do that for a living. Could you just explain the field and just tell us a little bit?
Okay, so most physicians that work in correctional health care now really had not planned to be a correctional health care provider or physician. Most of us sort of ran into this sort of accidentally, as I did myself. When I completed my medical training, which I had worked for public health as a health educator and also a health inspector, and before I returned to medical school and got my degree and finished my residency, I was really looking for a job in public health because I had worked in public health before and really wanted to come back and do what I had discovered was population medicine. So I was looking for a job in public health, and I ran into one of my Emory professors actually at the bank and said, there's this new agency that's looking for a medical director, and I think you'd be good for it. So she gave me this card. The job actually was only funded for 1 year, was a grant, and the person to be hired was, they had to be agreed upon by the then president of the Georgia AAP, as well as the then commissioner of DJJ. So they hired me with the thoughts that, I probably wouldn't stay so after I was hired, actually it was only like 2 weeks, we had a lawsuit and I had to address the lawyers and create, a medication policy. And then they said, I think you can, you've got something to do here, because they said, welcome, but we don't think you really have anything to do. So they found out quite quickly that I did. But the field of correctional medicine, if I can go back a bit, has a pretty dark history. We started out, and I like to always tell the story about women in corrections. Women were incarcerated early on by their husbands because they did not clean their homes efficiently.
Ooh.
So if your husband decided that you were not a good housekeeper or whatever, they could actually have you incarcerated in a women's correctional facility. And you have that history for women, but you also have the history of people of color, because after slavery, you did not have a workforce anymore, a free workforce. So someone figured out, well, how can we get this free labor? And they started incarcerating Black men in particular to do menial labor and free labor. You may have heard, I don't know, probably most of you are not old enough to remember the chain gang. Oh, yeah. Where people would be chained together to work on railroads and build America for free of cost. And the offenses that they were locked up for were really minor things, like standing on the block or walking on a sidewalk, for example. So you could be incarcerated for anything. So that really started the history of incarceration in this country, and it has continued with overrepresentation of minorities in correctional populations. So we've got, and the United States incarcerates more people than any other country, 1.8 million. We're number one in incarceration over any other country in the world. So when we started with the locking people up, eventually there were a lot of bad health outcomes because they did not have real physicians, licensed healthcare. If you injured yourself and say you needed a Band-Aid, you would barter with another person. Say they give you an aspirin for a Band-Aid or a cigarette for a Band-Aid. So that was the healthcare that we had before the 1970s. And a lot of the medical care was provided by other physicians that had been incarcerated themselves for fraudulent activities or, Medicaid fraud or whatever. So they were there and they would provide the care. So we had a very long way to go with professionalizing correctional health care. So in 1976, there was a Supreme Court decision out of Texas that stated that if you locked someone up, it was cruel and unusual punishment to not provide health care for them. Therefore, after that ruling, individuals that are incarcerated are the only population that are guaranteed to receive health care by the Constitution. And then most people don't realize that. They think that, individuals that get locked up, don't receive any health care. But if they don't, then it creates lawsuits and problems for the agency or whoever is incarcerating them, because it is a constitutional right. So what we've done in corrections since that time is try to create a professional atmosphere through several means. First of all, only hiring individuals that are fully licensed, that would be nursing, physicians, advanced practice providers, dentists. Anyway, you can't work in a correctional facility now unless you're licensed and don't have any sanctions on your license. And we also have professionalized our organization with the founding of the American College of Correctional Physicians. And that is an organization specifically for correctional physicians. And we have continuing medical education that's specific to corrections. And we have a meeting coming up in September, group chats. We do policies and position papers. For example, there was a practice some years ago of women that were in active labor being shackled to the exam table during active labor. So we fought very hard to stop that practice and have been successful in most states in doing so. And then finally, the ACGME has this year developed and put out a curriculum to actually have a correctional fellowship where individuals can go, physicians can go and get the fellowship accreditation, because we know that correctional medicine is medicine like anywhere else, but the environment is so different. We really needed training specific to physicians that worked in that environment. So long story short, that's sort of the history of correctional healthcare in a nutshell.
Excellent. I told you I was here to learn. I have no idea. So that brings me to, because you are the medical director, specifically for the Department of Juvenile Justice, help me to understand like what the process is. So I know you have nothing to do with their being there, but when a inmate, I guess, right, when they arrive, do they all like go through a basic screening? Do they tell you, I mean, what does that look like? Or are they only there, your team of healthcare professionals, are they only there in case somebody needs, or what does that look like?
Yeah. Okay. So what we've tried to do also is try to avoid the use of the term inmate, even though everyone knows what we're talking about. We try to use terms like incarcerated individuals or incarcerated youth. And so each system is very different with regards to how people get there and what's done when they do. So the adult system has a federal system. It actually has a set of prisons for military staff. There are facilities for immigrants. You've heard of ICE facilities. You have state adult departments of corrections that house adults for offenses. And then you have local jails for adults that usually are run by the county, local county jurisdiction. The way they get there is really up to policing and the courts. And I always like to mention that to people because they say, well, okay, why are you working in corrections? Why are you, working for to provide better care for individuals that have committed these offenses? Well, first of all, we know what the legal system is like, that we don't always get a fair shake, particularly if you don't have resources. So some people there may actually be innocent. A lot of them are there due to their circumstances, particularly children and even as adults, because they've been traumatized, their mental health conditions, they're homeless. There are a lot of reasons that individuals get incarcerated. For the juvenile system, it's much less structured than the adult system in the sense that each state operates differently. So in Georgia, the Georgia Department of Juvenile Justice does everything with youthful offenders. And so we have probation, we have long-term secure, short-term secure. So short-term secure regional youth detention centers are like jails, analogous to an adult jail, but you cannot keep children in with adults. There must be sight and sound separation. So even if a child ends up in an adult setting, they have to, say, for example, clear everybody out of the medical area for that child to come in and get treatment. So it is a requirement that there's sight and sound separation. Each state has different laws with regards to how old you can be when you're charged as an adult. So you can get adult charges, or you get charged with specific crimes all the way down to age 13 in Georgia. And you're considered an adult with regards to where you go, whether you go to a jail or juvenile setting at age 17 if you're convicted of certain offenses. So it is variable across states. Some states have the Department of Juvenile Justice is only responsible for long-term secure facilities. The county might be responsible for the detention centers. And even among those facilities, healthcare may be carved out. So healthcare may be a function of a private company, a private entity. The jail or prison may be run by a private entity, or may be run by the state government or federal government. Within medical, you have private entities, healthcare companies that run medical within corrections. You also may have, for example, public health partnering with the local jail or the juvenile facility to provide health care for those individuals. So in Georgia, all of our youth are served by physicians, nurses, PAs, nurse practitioners, dentists, psychiatrists, psychologists, et cetera, that are hired by Augusta University, which is the medical school for Georgia. So DJJ pays Augusta University to hire the clinical staff. The clinical staff is easier to hire them as clinical staff over at the hospital, on the hospital side, on the medical school side, and also provide things like CMEs, et cetera, that we can't do on our DJJ side. But they, within the contract, when DJJ pays AU and they pay the medical staff, they are mandated to follow all of my DJJ policies and procedures, protocols. I decide the medication formularies. All those things still run through DJJ, but it's just administered through Augusta University. And we have setups like that in different places, like in Texas, where they have university affiliations to provide health care for individuals that are incarcerated.
Is there any scenario, any diagnosis that would maybe change the juveniles time to serve? Or is there any time where, as a physician, you recommend, like, this is too, this is above what we're able to take care of because this is life threatening? Maybe I'm thinking of a lifetime movie scenario. I don't know, but is there anything that's just so dire for that incarcerated individual? I got it. That would necessitate you going back and telling the legal beagles that, hey, this is going to be disruptive or harmful.
Okay, so a couple of scenarios. First, with regards to the severity of the medical condition, we generally have to take care of everything. So on the adult system, they actually have full hospitals with dialysis units that they take care of all the individuals that are incarcerated in that system with specialists. I mean, you wouldn't know that it wasn't a community hospital unless, you knew that, you couldn't leave. So most adult systems have some access to that. There is some way in some systems that they can go back to the judge or the probation board, parole board, and ask them for what we call a compassionate release. But it's totally up to that parole board or that judge as to whether or not they want to release that individual. I've had some success stories and I've had some not so successful stories. And it really depends on the judge and whether or not they want to release that young person, or the parole board, whether they want to release that individual. But what we do when they come in, we do a full medical assessment. And I didn't give you the details of that, but in our system, within 2 hours of arrival, they get a health screening. We do not have 24/7 medical care, but a lot of adult systems do, where they have medical staff there 24/7 because, of course, the patients are there 24/7. So within 2 hours of arrival, we teach intake screeners, medical screeners. Medical staff teach them to use this form that's very straightforward to say whether or not you need to send the kid back out to the emergency department for clearance, or whether or not they need to be medically isolated, say maybe something infectious, cough, fever, et cetera. So we have a system in place for that. And then within the first 24 hours, they're seen by medical staff and do a complete, what we call a review of systems, check the history, initiate some laboratory testing, We do full screenings. We check for tuberculosis. We check for STIs. We also do some comprehensive blood work, blood count type work. So they get laboratory services. They get testing for infections. And then they're seen by a physician or an AAP within 3 days if they have a medical condition, or within 7 days for a full physical examination within 7 days. And then if they have a chronic medical condition, we operate chronic care clinics where they're seen every 30 days for medication management, et cetera. For example, our asthma clinic, we have spirometers on site, and that's a machine that can tell you how bad your asthma is or not. And so we have those on site. We provide sick call. Now, sick call is required across the system, and it has to be what we call unimpeded sick call access. So what most people have is like a drop box where the person requesting the care can write down what their request is, and they put it in a box that's locked, and only the medical staff can pick that up. And the nurse will triage that request, and then they're seen. Now, in my system with kids, there is no copay. In some adult systems, the patient may have to pay $5, $3 to be seen, unless it's something around infection or something around chronic care management. So those are the sick calls. We also do a screening for dental. We do everything for dental cleanings, everything but braces, prosthetics, etc. They get their teeth cleaned twice a year. They get oral health education. And then we have a full behavioral health program where we have counselors, we have psychiatrists, psychologists, and we manage all the psychiatric medications for those young people. Actually, all the medications for the young people, but the majority of our kids are on psych meds. And our greatest medical need actually is dental care, because most of those kids have not seen a dentist since the time they went into elementary school when they did that initial screening. And so they've never seen the dentist. So they come to us with caries, and we take care of everything.
And you started to address my next question, which was about behavioral and the mental, the emotional. Like, I can only imagine, especially if you are newly incarcerated, or those who already come in with diagnoses, even ADHD or
Yes,
like, I can't imagine, but could you speak to that a little bit more?
sure. So sometimes we have a kid that has been diagnosed in the community. But sometimes we don't, and there'll be a new diagnosis. But that's why we do a full assessment when they come in and look and see what the needs are. And sometimes we may change or modify the medications only because youth may have been in the community and seen 5 or 6 different providers and have 5 different medications to treat the same thing, but no one has looked at those meds to make certain that they're the most efficacious for that mental health condition. And we follow the kids. We have behavior programs where we give positive incentives for behavior. We're able to manage them, I think, much better because of the medication compliance. When they're with us, they will generally take the medications, but they're not forced to take medication. If they always have a right to refuse meds. They have to sign a form of refusal, and we have to notify the parent and the provider that they're refusing, but they do have that right. We also do a lot of group sessions, group counseling. We've started doing yoga in some of our facilities to sort of, and this is sort of a trend across the nation as well, in that, to teach that mindfulness and that control that you need when you go back out. And we're also working on what we call a reentry initiative, so that before the child leaves the facility, we look at everything that's needed when they return: housing, the family situation. We bring in the parents to discuss how we're going to manage them coming home. We look at education, and I'll divert a little bit to talk about education because that's so critical. Many of our kids come in, they're way behind in school for many reasons. One of the reasons being they weren't going to school, they were skipping school. So we're able to have them in very small classes, provide special education, and we not only will provide or get them a GED, but we also provide high school diplomas and actually have graduation ceremonies where we invite the parents to come in and witness graduation. They have a strong vocational education program, and some of our kids even take college courses online. So we're doing as much as we can to get them prepared for when they return to the community. One of the other great programs that we have is if they have tattoos that are visible, and oftentimes tattoos are done to show your gang affiliation. So if they're willing to go through a behavioral modification program and they really want to separate themselves from the gang, then I'll actually pay for tattoo removal so that when they go back to the community, they don't have that big sign to say, I'm a member of this gang or that gang. It allows them to have a little bit better chance to create some positive peer groups, boys, girls club, boys and girls club, things like that. We try to get them connected with when they're leaving, as well as job opportunities. We have partnerships with, for example, Home Depot and Georgia Tech, and training them for job placements when they leave. So we're really trying to change the life of these children so that they don't end up in the adult system. Many of them have had, it's generations of individuals that are incarcerated, or they unfortunately have been born to parents that were involved in illegal activities that involved the children quite early on for their own benefit, because they may have a third strike looking at them at the 3 strikes you're out. So they will have their child do the illegal behavior for them. You have that extreme, and then you have the other extreme where you have parents that are really, really trying and really good parents, but they just have such dire situations, being homeless, having to work 2 jobs and not able to be there to adequately supervise their kids. So we end up with everything. And most of the kids that we get have had traumatic lives, and it really has led them to the substance abuse, the mental health disorders, and ultimately to incarceration.
So this is fascinating to me because I promise you, I just never knew all of this was happening. So I got several questions. So I'm just trying to get the first question or statement. As you're sharing, I'm going, oh, so that means these young people are getting their vaccinations. I mean, they at the time that they're supposed to get it.
Yes.
Mind blown. I just didn't even think about that. And what about all the preventative screenings, right? Maybe pap smears and
we did everything. We stopped, they changed. I'm sorry.
You get mammograms at 40 and
okay. So yes, everything. So if you are a good correctional system, you're doing colonoscopies, you may not do them on site, but you're getting them done. Everyone has a template for what needs to be done at a certain age. And they may only get a physical, they're younger, say 25, 30 years, they may only get a physical every 3 years. But you have, for the young people that I have, they get annual physicals. They get their immunizations. They get, blood work every year. We provide special diets. So if they have allergies, we'll do an allergy RAS blood test to see if they're allergic to that food item and create special diets for them. So and that's across the board. You have the provision of special diets. You also have the provision of religious diets. So we have a lot of kids that practice other religions other than Christianity. And we have chaplain services that made sure that those kids can continue to participate in whatever religion that they are affiliated with, and have the food restrictions that that their religion requires as well. So all of that is a part of it's a huge system. And I tell you, people don't realize how good it is, but I'm telling you, if you're a physician these days, you really might want to consider working in corrections, because we don't have to deal with insurance, because we don't take insurance. We don't take Medicaid. We don't take Medicare. We don't, it's all state dollars or federal dollars or whatever it is. You have to provide the care because it's constitutionally mandated. Your patients will always be there for follow-up. You can, they get their medications because they're observed taking their medications, and you don't have to worry about, I don't have to worry about someone else deciding if a kid needs a surgery. I can make that decision.
That's what that was one of my other questions. I was like, because you're not getting parental consent, because they're now.
We do though. We do. Okay, so it's very complicated with kids in the juvenile system, because in some cases the parents maintain parental rights. So when a kid first comes into the system, we get consent from the parents for everything, immunizations, general health care, etc. If there is an invasive procedure, then we have a separate consent for that procedure. Now, if the kid is a part of the foster care system, and say the parents have not done what they should have done, and the kid is with defects, then it becomes a joint decision with us and defects. And then when we have two types. They're called committed and non-committed. So committed youth, DJJ can stand in loco parentis, or in place of the parent if we need to, like authorize surgery or do whatever, but we tend to still bring in a parent unless the parental control has been removed. And then of course the adults they have to consent for everything themselves over 18. And then for STIs, the young people have to allow us to provide that information to their parents for STIs, pregnancies, and mental health. Substance abuse treatment.
Okay, so my next question, I'm curious about and I know it's a lot, but what did it look like during COVID?
Oh man. Man, I'm still getting post-traumatic stress disorder from COVID myself, because I had 1,000 kids locked up and 3,000 employees that I was trying to manage with COVID. COVID, we had to have a lot of protocols, but unfortunately with corrections, we don't have any control over who comes in. So we can't say, okay, you look like you've got COVID, you can't come in now. You can't do that. You have to have the mask and try to isolate that individual. We were able to administer the COVID vaccination to the young people that we had and offer it to staff, that were willing to take it. So it was an experience. Fortunately, back years ago when we had the possibility of the H1N1 influenza outbreak, I had created a pandemic plan back then. So when COVID hit, I was able to pull that out and dust that off and make some revisions, and we were able to get through it. We did not have any youth to die. We did not have any youth to even be seriously ill enough to be hospitalized. We did lose about 3 staff members, but in general, I think we fared much better than on the adult side, because the adult side, you got really close quarters, and that's the perfect nidus for transmission of any type of infection, whether it's influenza, TB, COVID, or whatever. So you've got these really close quarters, and you've got correctional officers that are coming and going and bringing in, and even medical staff bringing the COVID into the facility and taking it back out. And then you've got a population that may not be the most healthy either, because remember, you've got some individuals that may have a life sentence or may have really severe medical conditions that are being exposed to COVID, and those were most of the fatalities.
Right. So, okay, I think the last two, I shouldn't even say that, but the last two things that I want to get you to speak to, if my loved one is unfortunately finds him or herself a part of this population, just share with the parents or the aunties and the uncles or whomever, just take away like how to advocate, how to advocate. I know someone, I'll just leave it at that, who is dealing with their own sibling, who is an adult who's incarcerated, and he was having like just some pain and wasn't advocating for himself. And she was just so upset. She's like, they need to do something. You can have a tooth abscess and yada, yada, yada. But I'm thinking about the juvenile population. Not that we do not even want them to be going through this. But if you find yourself in this, just maybe some things that they can advocate for their loved ones.
Sure, absolutely. And so we really encourage communication with parents. So we have advisory boards that include, each facility has an advisory board that includes parents and community people to sort of be there and have the pulse of what's going on in the facility. We provide, Halloween parties and Christmas parties and all those things for kids. If there is a problem, we have an ombudsman program, and that's pretty much everywhere. So you can call in and voice your concern to that ombudsman department. And usually those are included on the website of whatever correctional system you're looking at. And you can reach out to that ombudsman program to say, I've got a problem or concern, and they will investigate it and come back to you with an answer. The other thing that we do is we use a lot of video conferencing with parents. I had a young man that did have COVID during the pandemic, and his mother was so distraught, with him being incarcerated with us and having COVID. And so I arranged for her to have a video conference with her son so she could see he was doing just fine. But, you think the worst when you don't know. So that's another way to encourage that communication. There's always a possibility of picking up the phone and calling medical. So everybody has medical staff. So you call the facility, you ask to speak to medical, and then you can speak with the nurse. Usually there's a nurse manager or a health services administrator that you can speak directly with. And they can bring that person in and check them, even if they don't fill out a sick call slip or request themselves. If you have a concern, then we'll follow up on it as well.
And so I'm going to make this my last question before we let you do your call to action or your wrap up. As an OBGYN, I have had the experience of delivering women who are brought in from their incarceration and now they're in labor. But like, how are they taken care of? Because I've never been the one who has taken care of them in my office. It's just at the time water breaks or they're in labor. And of course, security's tight and they're right there and at the door. But how is that care provided? And does that differ from county to county or state to state?
So every girl that comes into us, no matter what age, gets a pregnancy test. So if we discover that she is pregnant, then we have arrangements with local OBGYNs for pregnancy care. So we don't do that. We'll send them out to that appointment, and then they'll send back and say, we need labs, this often, or, if there's a problem, bleeding or whatever, then we can take them to the emergency department. So we have systems in place at every facility that care for pregnant girls. We also have, we can't do rooming in, but some adult facilities will actually allow the mother to keep the baby for a few months. And then the baby has to go, you usually get defects involved, and the baby has to go to a family member or to foster care. And that's the same thing that happens with our girls. Most times a family member is willing to take that child. And we've had a couple of cases where the young lady wanted to breastfeed the baby. We couldn't bring the baby in for the breastfeeding, but we did allow her to pump the milk and freeze and keep it for medical for the family member to pick it up. So we try to accommodate as much as we can, but there is no rooming in for us. And we make certain, and I'll have to tell you this, years ago, before they made some of the changes to the juvenile code that we stopped locking up everybody for everything, we used to get a lot of girls that were runaways, and the judge would actually give them a sentence to come and stay with me until after they deliver, because they knew that they were going to have a good birth outcome if they stayed with me. That is not the way to do it, people, but that's what they used to do. So now we have other avenues where they can be cared for out in the community and still have that good birth outcome.
Got another question. I'm sorry, I lied, because it just made me think. Before the overturning of Roe v. Wade, are incarcerated women allowed to, or were they allowed to choose to terminate their pregnancies?
Okay,
And was that an offering?
again, it varied from county to county. So we never used state dollars to pay for abortions, but what we would do, if the girl wanted to have an abortion and the parent wanted to allow them to have the abortion, we would go to the judge to ask if we could have the girl released for the procedure. The parents would pay for it, and then we would come back and provide the care after the procedure. Some judges would allow it, some judges would not, because we had to have a judge's order, in order to have them to be released. I only had one, I believe, that did not want to release her for that, but fortunately, she was able to be released from the facility. The charges ended before, it was too late for her to have the procedure. But that's how we have handled abortions in the past. Yeah.
Y'all see, I am fascinated. I'm going to have to call Dr. Staples-Horne on my own time. Like, I got another question for you. Thank you so much.
Fascinating job.
Do you have any takeaways that you want to share with us?
Yes. The takeaway is, remember, correctional medicine, correctional healthcare is a profession, and that we do a great job in taking care of the individuals once they get there, in most cases. But not every system is the same. Some systems don't have the level of healthcare that we have here in the state. And so if you're somewhere else, or your loved ones gets incarcerated somewhere else, you need to make sure you look at that system, that you make those calls to make sure that they're getting the care that they are constitutionally mandated to get. There are a lot of people that put lawsuits in order to get the care that they need when it's not occurring. That is another option. But the biggest takeaway is to look at the laws that got so many individuals locked up. No one ever, like that old saying about going upstream, to see who's throwing the bodies over. We're down here downstream trying to pick them up and take care of them. But the laws, a lot of the laws that were passed, that have created this huge population of incarcerated persons, the laws, the lack of substance abuse treatment, the lack of mental health treatment, all these things are community initiatives that could be made in order to treat individuals in the community so they would not commit the offenses that got them locked up. and also dealing with things like homelessness, lack of educational or poor educational systems, all those things, all those social determinants of health really fit quite nicely into why individuals end up being incarcerated when you don't have those structures in place. So I encourage everyone to advocate for making certain that all of those determinants are out there for everyone, and to make certain that you look at your system, your judges, your officers, your probation, parole system, and your justice system, to make sure that those individuals that are there are being treated fairly and that they receive all the health care that they are mandated to receive.
Yes, thank you. Thank you. So thanks once again for Dr. Michelle Staples-Horne for taking time and sharing this very vital information. And thank you for watching once again The Pulse. We'll see you next time.
Thank you for the opportunity.
The content shared on this podcast is for informational purposes only and is not a substitute for professional medical advice, diagnosis, or treatment. The views expressed by our guest and host are their own and do not necessarily reflect the official positions of GSMA. At GSMA, we stand on over 130 years of medical excellence and advocacy, but we encourage you to always consult your physician or qualified health provider with any questions you may have regarding a medical condition. If you think you may have a medical emergency, call your doctor or 911 immediately. Until next time, stay informed, stay empowered, and stay well.